then the third client is a patient who has granulation tissue or granuloma of the eardrum. For anyone who doesn't know who I am, I'm a UK-based consultant audiologist and clinical ear care specialist, and I'm also the founder and director of a company called Clearwax, and Clearwax are the manufacturers of the iClearScope endoscope device that we're using to perform these procedures in. So this is the first patient with surface ear, and I'm just using a Jobson horn just to get in behind this dry wax. So what is surface ear? Surface ear, you shouldn't mistake it with swimmer's ear. Swimmer's ear is when you get an ear infection due to water entering the ear. Surface ear, in a sense, it can be similar, but it's typically when it's cold water or cold wind. So a lot of, obviously, surfers, if they surf in cold water, or people who are out and about, kiteboarders, etc., people who are exposed to cold air, cold wind, the bony part of the ear canal, you get abnormal growth, and there's typically 3 growths. You get one at 2 o'clock, 6 o'clock, and 9 o'clock. People with swimmer's ear who, surface ear, who surf in cold water, I think 6 times more likely to develop these bony growths. So it's called, another name is exostosis, and they're 6 times more likely to develop surface ear than surfers who surf in warmer water. And it's just a bony part of the ear canal. It's absorbing some of the minerals, the coldness. So when it evaporates, the bone kind of just, you get kind of fresh bony growth. I've never come across someone with exostosis whereby they need it surgically removed. So if it's a mild bony protrusion and it's not impacting the hearing, then you can, typically it's just, well, left alone. But some people can develop chronic ear infections. Water can get trapped in behind the bony protrusions, also earwax, dead keratin, and sometimes the bony growths get so large that they constrict the ear canal completely, and it leads to a conductive hearing loss. So this patient also has tympanosclerosis, so scar tissue of the eardrum, and you'll see that you've seen the bony protrusions a few times, but there's one in this case more at 12 o'clock. There's a second one at about I would say 4 or 5 o'clock, and a smaller bony protrusion more at 7, 8 o'clock. And the patient did confirm to me that they used to swim, not used to surf, used to swim in cold water quite a lot. So you've got one at the left, one on the right, one at the top. And you've got the white patches, that's tympanosclerosis, that's calcification, scar tissue, and that normally occurs. The eardrum itself has three membranes, and that one typically has in the middle membrane. Secondary to chronic ear infections or acoustic trauma or physical trauma or barotrauma, which is a sudden pressure change of, so any trauma to the eardrum, really, you can get that calcification. And that calcification can also, again, leads to these bony protrusions. So it's kind of, in a sense, linked. The second patient attended with otitis externa. They had been, I think, on repeat prescription for a few weeks now, just antibiotic ear drops. She was also advised to use sodium bicarbonate drops, which may have actually made it worse. Sodium bicarbonate drops, but the patient doesn't have wax, so you don't need to use sodium bicarbonate drops. You just saw there, I just put some suction in, and a lot of that fluid got vacuumed up. And you also saw the ear canal close in a bit, it collapsed, and that's when you've got otitis externa. You've also got edema, swelling, inflammation. Well, not always, but in this case you have, of the ear canal. And when you put a suction probe into the ear canal, when you've got this swelling, inflammation, edema of the ear canal, remember, swelling is generally fluid, and this suction probe is sucking the fluid within the swelling, so the ear canal, it's getting sucked in almost by the suction probe, and it can close in. So just going back to the sodium bicarbonate. Sodium bicarbonate is water-based and it's alkaline. The ear canal is slightly acidic. It ranges from 5.8 pH level to about 7. And people who have otitis externa, which is an inflammation or external ear infection, when they've measured the pH level, it's turned from acidic to an alkaline solution. So, and the idea with many of these antibiotic drops is to re-acidify the ear, make it, turn it back into an acidic orifice canal, and the acidity helps inhibit certain bacterial growth. So using sodium bicarbonate drops, actually, you're just keeping the ear alkaline still. And also, because it's water-based, water is it's a big no-no for the ear. We should all of us, even if we don't really have ear problems, avoid water entering the ears because that can lead to an ear infection. So I've got the main occlusion out of the ear canal with a Zollner suction probe. I'm just using a fine end tip now. The ear canal is quite narrow, so it's hard for me to, well, I can get into the ear, but it's limited freedom of motion in there because of the swelling. So I'm just going to be trying to, with otitis externa, one of the best treatments actually is just trying to give the ear a thorough clean, get all this dead keratin to dead skin that's coating the ear canal. Just clean up as much as you can. I know one of the viewers is very keen, and I think they're from America. They use dry mopping quite a lot. So dry mopping is a technique where in the UK we use a Jobson horn, so an ear correct, and on the reverse end you've got a serrated edge, and you get a piece of cotton wool, I would say about the size of a stamp, and you fold it over and you twist it on the serrated edge, but in the opposite direction. And when you go into the ear canal, the idea is you go in with the cotton wool and you spin it in the ear canal. And it's called dry mopping because it kind of mops up a lot of the debris. Now, as an audiologist, I don't do dry mopping. It's really fallen out of favour in the UK, actually. So I was asking one of the surgeons, well, why is that? And they said, well, two reasons really. You get a lot of loose fibres. And these fibres remain in the ear canal, and that can be kind of some sort of scaffolding almost for bacteria to grow on. Secondly, the skin. So the skin in the ear canal, it's got a unique property to naturally migrate out of the ear. So if it didn't have that ability, once it's died and shedded, everyone's ears would be blocked of dead skin, dead keratin. So it's almost like a snake skin. So the top layer of skin, the epithelial skin cells that are the outer layer of skin cells, as they shed and die, they move laterally, so sideways out of the ear canal, and it's a natural conveyor belt motion, and that's to expel the dead skin from the ear so it doesn't block up. But any earwax that sits on the dead skin, it can also help to migrate the wax out of the ear as well. So it's almost like a transport mechanism. If you're grazing the ear canal with a bit of dry mopping, not only are you exposing that outer layer of epithelium skin cells, you can cause a bit of bruising as well because obviously you're spinning this, but you're killing that layer of epithelium dead skin cells. So here we're just peeling the outer layer, so the inner layer we're trying to keep intact. This layer is dead anyway, but we're delicately kissing the surface. We're not, so we're removing this dead layer of skin, but the one underneath we're not. But when we're dry mopping, you can abrade that undergrowth, the fresher layer of epithelium scales. And what happens then is your ear loses that conveyor belt motion. So you can get a buildup of dead skin, wax in the ear. And finally, the inner 2/3 of the ear canal is made up of a thin layer of skin, like 0.1 millimeters, that coats bone. And that bone is very sensitive. And you can probably see with this patient, just a bit further in, a bit more medial near the ear canal, near the eardrum, there's a narrowing. You can probably see that. It's a bit further in where the suction probe is. That's called the isthmus. And if you get beyond that point, it narrows and it widens, and that can be like a pressure point. And if you get into there and you spin something, it can be very uncomfortable. I mean, I've had I'll be honest, years ago, before I was an audiologist, I put a cotton bud in my ear, and I went into that isthmus and I spun it, and it was so uncomfortable, it was so sensitive. And if you make contact with this dry mopping, you're going to touch the ear canal. So it's just a thing in the UK. I know in America they use it. A nurse is a follower, and I think she's a clinical ear care specialist as well. So different countries have different trends. It's just in the UK, it's just fallen out of favour for those reasons. I mean, people who perform in America might kind of have almost have a counter argument against that. But also, as an audiologist, we can use an auto block. So an auto block is, we use an auto block. So it's like a piece of cotton wool, basically. You're less likely to get any fibrous wool fibres stuck in the ear with these auto blocks. But we use it when we take ear impressions. So like dentists take dental impressions for braces and retainers. Audiologists take ear impressions, we call them oral impressions, and we use that for ear molds or hearing aids that fit in the ear. So we take a cast of the ear. So an autoblock is a little piece of cotton wool, we've got a string attached to it, and we insert it into various lengths and depths of the ear canal depending upon what type of mold or hearing aid you want. And we then syringe some putty material basically, and this impression material, like putty material, it sets. So when you inject into the ear, it's the same stuff as the dentist use really, and it's quite soft and runny at that stage. Then after 5 minutes it sets, and we pull it out and we take a cast of the ear. So sometimes, I mean, if you've got a patient with bleeding in the ear and you want to compress it, or you want to do a bit of dry mouth, you can just put a bit of an autoblock. Problem with an autoblock, when you push it in though, you could graze all of this debris around the side of the ear canal and push it further in and impact it on the eardrum. So I just much more prefer just using a fine end gauge. It takes a bit longer, but we're not going to cause the patient any discomfort, especially in this isthmus. You can see, I'll kind of highlight where the isthmus is, so with a suction probe. Just at this point, you can see where the ear canal narrows and then it widens, and where it widens, you've got this hidden cravat. We call that the anterior recess, and if you've got a dry mop there and you're spinning it, well, believe me, it's not going to be comfortable. So, as I mentioned a bit earlier, the idea is someone with otitis externa just want to remove as much debris as safe as possible. Once you remove the debris, then the antibiotic eardrops that the patient's got is going to be far more effective. The patient could hear really, really well at this stage. They were really over the moon. They were really happy because they've not been able to hear for a few weeks, and it's been really isolating for them. But because the patient was very still and they weren't experiencing any discomfort, I kind of just carried on, nice and gently, delicately, just removing as much debris as I could. So the eardrum's in view, it's intact. I did a test, tympanometry. It's a pressure test just to see how well the middle ear. So the middle ear is made up of the eardrum, the 3 ossicles, so the 3 middle ear bones, popularly better known as the hammer, anvil, and stirrup, but medically they're known as the malleus, incus, stapes. So when the sound hits the eardrum vibrates. The vibrations cause these ossicles these bones are all connected together to swing backwards and forwards almost like a pendulum. And the last bone, so the stirrup, what we call the stapes, is connected to the organ of hearing called the cochlea. And when the stapes or the stirrup moves backwards and forwards, it stimulates fluid, inner ear fluid in the cochlea, the organ of hearing. And this fluid then travels in waves, and these waves themselves travel over little tiny microscopic outer hair cells. And when these hair cells vibrate, they produce an electrical signal which is sent to the brain via the auditory nerve, so the 8th nerve, the hearing nerve. We process that as sound in the auditory cortex, which is a part, if you're right-handed, the auditory cortex is typically on the left side of the brain, and however, I think some left-handed people, they can have the auditory cortex on the opposite, the contralateral side of the brain, so the right hemisphere. So I did a pressure test to see how well the eardrum was vibrating, to see whether the eardrum was not too thickened or stiffened, or the bones were all kind of connected, because they can become disarticulated, so disconnected, or the bones can become stiff, and that's called otosclerosis. So if the bones are stiff, the eardrum becomes very turgid, the sound hits the eardrum, it bounces back out. We also evaluate the function of the eustachian tube, so we want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere. And when the air pressure either side of the eardrum is equal, that's when the eardrum is at its most mobile. And we've got the eustachian tube, which I've probably talked about a lot in the past. The eustachian tube is a narrow orifice tube that connects the back of the eardrum, so the middle ear, to the back of the nose, the nasopharynx, and that tube regulates the air pressure. So when you chew, when you yawn, for example, this tube momentarily opens and it allows air to enter or escape, and it also allows for middle ear fluid that collects behind the eardrum to drain out. So that's the end of this procedure. The patient's going to continue to use their drops. And the last one is a granuloma tissue. Again, they've got an infection. You can see it's very misty, very liquidy all over the eardrum, but just to the to the top at the moment, you'll see this red kind of red marks. So what is a granuloma, granulation tissue? Granuloma, I believe it's formed by the most inner layer of, you probably mentioned, if you heard me earlier, the eardrum's got 3 membranes, and I think the granuloma, granulation tissue stems from the inner layer of the membrane. And it's basically a form of connective tissue and blood vessels that form during a healing process. So whenever you have a granulation tissue or granuloma, you know there's been some sort of infection and the ear's trying to heal itself. And on this patient, you can see it more now, it's become more apparent. It's to the rear, to the left, and this can protrude outwards, and it's a very rough edge. You'll see it at the end of the procedure. I think I've taken a still image of it. You'll see this granulation tissue, red mark on the left hand side. It's got a very rough appearance, and some people can develop granuloma, myringitis, and basically you've got the granulation tissue all over the eardrum, sort of this little segment. You can also have these forming on the ear canal wall. Treatments are basically antibiotics. Sometimes they have to be surgically removed. They can just resolve themselves, but when you've got a granulation tissue, you can be quite sure that the patient has got a conductive hearing loss, so the sound is not being conducted. As I said, if you remember in the last case, the sound waves travel to the ear canal, it hits the eardrum, and the eardrum vibrates, and these vibrations set off the bones, and the last bone then stimulates the organ of hearing, which then sends electrical signals to the brain, and we perceive that as sound. Granulation tissue, so granuloma, can affect the vibration of the eardrum, basically. And also, this patient has got, let me give you a bit of a backstory actually. This patient has been suffering for, I think, a few years now. I don't know why, in fact, I've got kind of, let me just look at the notes and remind myself. So, they underwent a hearing test at work, so occupational health hearing test, which diagnosed a right-sided hearing loss, but the hearing test was a screening test, so the patient was unaware whether the hearing loss was due to permanent damage to the organ of hearing, so what we call a sensory neural loss. So sensory neural loss is when you've got damage to the organ of hearing, the cochlea, and or the hearing nerve, the auditory nerve, or whether it was a conductive loss, so can the sound travel through the eardrum. So that's back in 2004. Let's have a look at the notes again. More recently, nothing was really done about that, and that's quite surprising, because when you've got what we call a unilateral, so a hearing loss in one ear, or an asymmetrical hearing loss, that needs to be investigated. You don't want to leave that on alone, because it sometimes can be really kind of quite serious conditions that can lead to that, which needs further investigation. In any case, more recently, that was 6 years ago, so I'm assuming this infection wasn't as bad then as it was now. But more recently, they went to a big high street chain who advised that she had earwax and to use earwax drops. And so that's what the patient did, and booked with myself. And I explained to the patient, you don't have earwax, there's no earwax at all. You've got this infection. But also, this patient's eardrum is retracted. So the eustachian tube, which regulates the air pressure, remember, you want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere. This tube behind the eardrum that connects to the back of the nose, the nasopharynx, regulates that air pressure. That tube is blocked in this patient, and it's typically blocked at the back of the nose. When that tube is blocked, it creates a vacuum. There's no air behind the eardrum, so the eardrum literally gets sucked in and gets pulled in like a vacuum. And you can see it's sucked in, so just there where I'm looking at now, that part of the eardrum on the left hand side is sucked into the middle ear, and also the attic, the top part where I'm looking at now, that's also retracted. And you may have noticed whilst I was talking, that attic region, there's a lot of dead skin, so this stuff that I'm peeling around the edge, that's just dead keratin, and there was a bit of keratin left in that attic, the retraction pocket. And I really wanted to remove that, and I've cleared most of it, because that keratin, if it collects in that retraction pocket, it can then form like a dead skin plug, which can develop into a cholesteatoma, which can be very, very serious. So I wanted to make sure I remove that dead keratin. I'm just trying to remove a bit more, but this keratin here is we're not as worried about. It's in that attic, that little pocket. So this patient's got several issues. She's got an outer ear infection, because you saw that kind of fluid, that kind of what we call outer ear, the ear pus. She's got a retracted eardrum, so the eardrum's buckled inwards, the air pressure, the eustachian tube is blocked. So not only does the eardrum get suctioned in when you've got a blocked eustachian tube, middle ear fluid. So you've got mucosa. Mucosa is like you get it in your nose and your mouth. The mucosa is kind of like a layer of skin where all the blood vessels are. So it provides the blood flow to the middle ear, all the skin cells in the middle ear. That middle ear mucosa, that can leak out fluid. And this middle ear fluid, so you can see I'm just going back into the attic trying to remove a bit more dead keratin there. This fluid generally drains out the eustachian tube, but if that eustachian tube is blocked, it's like a blocked drain pipe. And that then develops into acute otitis media. Otitis media is kind of a middle ear infection with effusion. So effusion is middle ear fluid. We can typically call that glue ear. And when you've got fluid behind the eardrum, again, your eardrum's not going to vibrate. And that fluid does need to be drained if the eustachian tube can't drain it. And that's when ENT surgeons, they perform myringotomy, and insert a grommet. They put a little hole in the eardrum, they suction out all the fluid, which turns into a glue-like substance, hence the name. And to prevent the fluid forming again, a little ventilation drainage tube is inserted called a grommet. I'm not sure what I think it's just called an ear tube in America, if I'm correct. But in the UK, we call it a grommet. There's two types. There's a Shah grommet, which is a kind of a small white, well, in the UK it's white, I'm sure they get different colours around the world. They typically fall out 3 or 4 months, and these grommets, they do naturally migrate out of the ear. Sometimes they're loose in the ear canal and they can have them removed. They don't really cause a nuisance. Or you can have what we call a T-tube grommet, which is a longer one and it extends further into the ear canal. And they're more long-term, so people with chronic eustachian tube dysfunction or chronic glue ear, they're less likely to fall out very quickly. And they can really extend halfway up to the ear canal. I'll try and put some images up of these. I'm going to try to do some more presentations and talks, because I know some guys just like the videos, and that's fine. And but some people really like the commentary and learning about the ear. I just got approached by the International Synopsinism of Audiological Medicine in India. They're doing their annual conference. It's an international conference that's being hosted in Bangalore, India. Due to COVID this year, they wanted to know, they're doing a virtual event, and they wanted to know whether I can do a talk on cerumen management. Cerumen is the medical term for earwax. And so a lot of these people are watching my videos, and they like to hear the commentary and the narration and learn more about the ear. So just a still image of this granuloma, this granulation tissue. It's posteriorly, so to posterior means to the back of the eardrum, to the left if it's the right ear. I'm just mopping up. The patient could hear significantly better. However, I did do tympanometry, and the patient, has got a bit of fluid behind the eardrum. I recommended some nasal decongestion spray and the Otovent nasal balloon to help unblock that eustachian tube. And I've contacted the GP saying they do need to be seen by ENT. I mean, this infection's been there for a long, long time. There's a severe retraction of the eardrum. She's got an attic retraction, so there's a chance that she can develop a cholesteatoma in the future, but I think it's self-cleaning, so I'm not overly concerned by that. But this granulation tissue, sometimes they have to cauterize it using silver nitrate to kind of get rid of that granulation tissue. Anyway, I know I talked a lot in that video, guys. I hope you enjoyed that format. I'm trying to make it educational for both other audiologists who obviously I get a lot of contact and they ask me to do so, but also I've tried to use terminology that people of the public can also relate to. Have a great weekend, guys. I hope wherever you are in the world you're keeping well and safe, and I shall upload some new videos.